great. It's amazing to see such a turnout. I think we're so pleased and thankful to all of you for voting with your feet and for making the time to be with us here this morning. A very exciting event. Welcome also to our online audience. So this is an ECLLA multi-stakeholder panel discussion here in Stockholm alongside the EHA Congress. My name is Dennis Costello. I'm the director in another life of the CML CML Advocates Network, which is a global patient advocate network in the rare leukemia CML. But this morning, I'm going to be your chair for this event, which is entitled Time-Limited Treatment in CLL and the Holistic Impact of Treatment-Free Periods for the Patient, the Care Partner, and the wider CLL community. I think this is also a very, very important moment, and we need to recognize that for ECLLA, the newly formed European CLL Association, as it begins its work to strengthen European dialogue on matters that really truly matter to CLL patients. So well done, ECLLA, and thanks for sharing this moment. And we'll talk a little bit more about this initiative and what we can expect from this initiative later on in the event today. So what can we expect this morning? As we know, as many of you know, CLL is increasingly managed as a long-term chronic condition in which patients may move through different phases of active monitoring, treatment, periods of treatment, and sometimes even retreatment. There have been advances in fixed duration and time-limited therapies that are changing what's possible clinically. But today, we're not going to look just purely at the clinic. We're really going to look more broadly and try and look, as we said, at that really holistic aspect of the patient's journey and living with CLL. We'll be asking, what does time off treatment really mean for the daily life of patients? And our focus today, as you can see, is really not to get into presentations or anything like that. It's to really have a balanced, practical, patient-centered conversation. We'll be looking at the clinical, the psychological, nursing, policy, patient, care partner, and patient advocacy perspective. So really a very wide gambit of perspectives that we can look forward to over the course of this morning. So with that, I'd really like to take a moment to welcome our panel. Beginning with Jan Ryn. So Jan is from Dublin, a patient herself of many years, chairperson of CLL Ireland, a co-founder of ECLLA, and with a rich background in patient advocacy and lived experience. Welcome.
Thanks,
Felice Bombacci from Italy, himself a CML patient, but also with the perspective of a care partner for CLL. Felice has done a tremendous amount of work in Italy for blood cancer patients and a very well-respected member of the wider international patient advocacy community. Welcome, Felice, and thank you for joining us today. As we move into the clinical side of things, we have Dr. Kostas Stamatopoulos from Thessaloniki. Welcome, and thank you. We'll really look forward to sharing your insights into how the clinic looks, how it's changing, and even the future, because I know you have a very rich and interesting background in the research and the biology of the disease, as well as the involvement of patients. We have Dr. Tal Munir from Leeds, specialist in hematology in Leeds, who is a little late. He's on his way. There was a confusion with the number of Clarion hotels here in Stockholm, but he will be with us, and we'll be happy to welcome him when he does join us. I'd also like to take the opportunity to welcome Monica Rakovica from MPE. Monica is her role is there as Access and Policy Manager, and we know that Myeloma Patients Europe have done a tremendous amount of work in this space, in the policy space, in the generation of evidence and patient preferences, and really, I'm really looking forward to the input that you can bring from that space to the CLL conversation that we're going to have here this morning. We have Professor Amanda Crayson from Dublin, who is an academic psychologist at the National College of Ireland, but with a real speciality in, psycho-oncology and cancer-related well-being. I think it's a field that we're all very much growing interest in this space, and it's really so important for us in the space of CLL, but for also, I think, for us to get a full holistic understanding of that. So thank you for joining us, Amanda. And Eugene Byrne is a clinical nurse specialist from Dublin, St. James's Hospital, bringing to us really that important relationship that nurses and the psycho-oncology space can bring to the panel discussion this morning. So thank you, Eugene, for joining us this morning. To anchor the whole conversation this morning, I'd like to turn to you first, Jan, really, to talk to us really about, what in the daily life of your own life, but also the patients that you see in your, in the patient organizations, what does it mean, what does time off treatment really mean in the daily life of a patient, in 2026?
Yeah, sure. Hi, everybody. I'm so pleased that you all came today. I'm really excited about today's conversation. And thanks to Dennis for facilitating, because we really need you, Dennis, and draw all the interesting perspectives out. From my perspective as a patient, and the most important thing, and I think I can speak for patients on this one, is choice. Choice, treatment options, an ongoing conversation about longevity, well-being, survivorship issues. And that might look a little bit different for each patient because we're all so different and our disease is heterogeneous. But I think what a fixed duration therapy treatment might offer some patients over and above a continuous treatment would be time off treatment. And that means, again, different things for different patients, but ultimately some patients will really welcome the opportunity maybe to take their foot off the pedal in terms of how they might, how they live their lives, maybe not swallowing pills every day. Maybe psychologically moving away from the CLL space for a little while. We know that potentially they'll need to retreat their disease at some point, and I think patients might need some reassurance around what the next step might look like. But there are a lot of patients, particularly I would suggest patients who might have younger family or who are in full-time employment, who would like the opportunity to not be treated for a while.
Mm-hmm. Because in the clinic, I mean, it's a rapidly changing space in CML. Thankfully, we can, I think, probably broadly say. But could you give us an overview, of how things have changed so fast in the past couple of years from the clinical perspective in terms of how you're seeing that from your side?
Dennis, I would have never expected what we're experiencing today.
Right.
Things have changed so dramatically in less than 10 years. It's a moving sand. It's moving sand. And sometimes when I talk to regulators, I don't know if you've experienced the same, and the myeloma people have been there before us. We don't have a fixed treatment landscape. It's changing fast. This is very positive, but this also raises several issues and creates challenges that we need to address. The challenges are how to best inform our patients and how to obtain the evidence that we need that would convince the authorities and the payers. It's not easy. There is another major challenge, and this has to do with physicians' perceptions about what is best. You've been there in CML before us, because you had this, you need to get your TKI every day. And then there was a possibility of stopping TKIs. And I know, and I'd like to hear, Amanda, what you will have to say, that this may create another issue, another challenge to both healthcare professionals but also patients. And this is cognitive dissonance. It's two things that are equally true, but don't necessarily make sense. I'll give you another example, and this is almost particular to CLL, active monitoring. So you're diagnosed with a cancer, but then you're told that you don't need treatment. Is it true? Is it correct? Yes, it is. Does it make sense? Not very easily. So it's the same with having having as a standard of care continuous treatment until a couple of years ago, and now hearing that time limited is what we should be striving for. It's not easy, which means in the end that we need to educate, and we need to educate healthcare professionals, we need to inform patients and educate patients, and we need to collaborate towards making this new standard of care a reality, but something that is acceptable by everyone.
Right. Thank you for that. And I mean, I think we'll get into a little bit more later on when we talk about co-decision making, about, I suppose, some of the nuances about how you communicate the complexity of the decision and so on to patients. I'd like to turn to you, Felice, as well, in terms of, we spoke a little bit about the paradigm of active monitoring, and I suppose the uncertainties that, you know, patients and care partners and families often have to deal with, you know, during the whole process. How, you know, how would you characterize, based on your experience, what your needs are, or how you might like to, I suppose, interact or best interact with the care team around dealing with these uncertainties?
Yes, because a lot of things is not clear for the people who don't live with the problem. When you stop a treatment for physician is a success, because it's the condition to give the new life for the patient, but for caregiver, for patient, is a anxiety, is a watching worry.
Yeah, yeah.
Like continuous means if the disease restart, if the disease come up, how I manage? It's possible to have a cure another time, or the drug before. I leave this situation. You means the CML filed. I live with the CML, and I stopped treatment in 2014. But a lot of people with the CML don't like to stop. When the day before say, I have a lot of side effect, I need to reduce dose. When the physician say you are able to stop treatment, the caregiver, about the patient also say, just a moment. For me, is the barrier for disease. Without drug, I have a problem. So it's a complex. It's not simple. We need to educate. We need to just to work with the patient and to with the caregiver also, because CLL patient is not younger. Many times is not like you. And a lot of people is very elder, and the caregiver take in the hand the life of the patient. And in my experience is most important how the caregiver communicate with the patient, reduce anxiety for caregiver and also for patient, if there are a good connection with the physician.
Right.
If the physician say, if you see this problem, please call us. If you see this problem, please, this is the solution, don't worry. But many times we are just stop treatment and no have any information more.
Right. Thank you for that. And I think you've touched on such a number of aspects of living the disease, you know, from that perspective. You mentioned anxiety, and you mentioned, you know, I suppose many of the aspects that we don't see, you know, that the patient community is well aware of. A lot of work has been done to surface, I think, some data on how the community is living that aspect. Last year there was a report that brought, you know, the Global CLL Community Insights report, which gave us some very interesting findings and data. It said that 66% of patients reported anxiety following diagnosis. That's quite a large percentage of the community if we look at it. I'd like to turn to you, Professor Crayson. You know, from the psychological perspective, why is it so difficult? Or, you know, could you give us a perspective into the paradox, I suppose, of, you know, on the one hand it's good news, but on the other hand you're living with this watch and worry, as Felicia just said.
Yeah, thank you so much. And I appreciate Costas kind of set that up for me, of just, I think a lot of the challenge here comes from this idea of when we think that we're being active, we're treating, we have a paradigm, an idea of what that looks like. So when we're being told that there's these, I often talk about it with my clients and patients, there's different chapters of treatment, and we need different, but that can be really difficult, and that's a cognitive shift that has to take place. But I think we don't do, and I really appreciate you talking about that space, that time for discussion, because to be honest, what we really need and as Jan mentioned, it's individual for each patient. Each patient needs to walk those chapters in a way where they have information, they have opportunity to talk about what's important to them. It really is about relationships. So having time and space to be able to talk about that. A lot of times if we're just told information, we may hear it, and we know there's a lot of research showing how hearing information may need to hear it many times, the conditions under which we hear it, how we remember things, but we need opportunities to have those conversations, and it doesn't just happen once. I think a lot of times it happens once, and well, they've been told that, they know that. Oh, do they? Have things changed? They've gone home and thought about that. And so really one of the things I'm always advocating for is we need more time and space. And that's hard in medical systems. But we need relationships, we need more time and space, and we need to be able to talk about how patients' understandings of what their treatment, what their needs are, what their caregivers' needs are, how those change over time. And I think the people in this room and our clinicians are, all of us on multidisciplinary teams are very well intentioned. I think a lot of times it's structural issues that limit that. But I'll talk more about some of that as well.
Okay, Costa.
So Amanda, isn't it where support by peers plays a major role? Because in the end, the structural challenges are high and they vary across Europe, but I am not aware of any European country where the system is ideal
Right.
and offers chances for seamless communication and for the time patients deserve. So in my experience, at least, referring patients to patient advocacy groups, particularly about this aspect, is key.
Absolutely. Now, there's a variety, and a lot of times we think about it in terms of intensity. There's going to be some people who are going to need to see psychology, psychiatry. There's going to be some people who need to see other people on the team. And the majority of people cope and manage relatively well on their own with good relationships, but one of the biggest benefits that can help is a peer support community. I just think we have to be thoughtful. I 100% agree, the research is really supportive of that, is that we don't outsource things though. I think we need both. We need strong systems that we can always improve, and we need to be providing good information and knowledge and elevating and referring and validating how important peer communities. There's nothing like somebody who's walked the same path as you. That's always going to be different than a clinician who doesn't have that same lived experience.
Right.
So absolutely.
One of the reasons I think we're holding this meeting today as well is to really address now some of the real gaps that we can see in terms of the opportunities, but what is actually being lived by the patient community as we face up to these. One of the things that struck me, and I'd like to turn to you, Eugenia, on this, was that, again, invisible things that we don't see. 52% of patients self-managing symptoms without professional support. That must create another, a huge burden on the patients themselves. You in your work, as a psycho-oncological nurse, working with patients, how do you see patients assuming that burden, or how does that come out in the relationship that you would have?
Good morning, everybody. I was just listening to the report there from CLL that you mentioned, that 66% of patients report anxiety.
Yeah.
I have a philosophical approach that anxiety is a normal part of life. It's part of the human condition. We all experience anxiety, but to what degree do we experience that anxiety? So in reports like this, it can be unhelpful to just say that patients experience anxiety. In my clinical practice, we work with mild, moderate, severe, and that's done through diagnostic interview and clinical expertise. So I think part of that as well would be when we're on the on-off periods of treatment. One of those bits would be patients' health literacy as well. Have we assessed that? Have we considered that when we're in our interactions with patients? And the final bit to that would be managing the anxiety and uncertainty about, like they say, I'm well, but I'm not. It's a conflict between I have a cancer diagnosis, but I don't have. I'm not being actively treated, and the juxtaposition that puts people in is very difficult for people to tolerate and manage.
Yeah. Jan, I'd like to come back to you, having heard all of those different perspectives, how would you like to react to that in terms of what you hear or what you think is still needed or what the focus we'd like to put on that in today's conversation?
Yeah, I think so. I think we are kind of guilty of potentially conflating active monitoring with time off treatment periods. And they are a little bit different because active monitoring will happen at the beginning at a diagnosis, and patients will likely have to grapple with a lot of kind of the psychological toll of that early on. The option for time off treatment or fixed duration treatment means that patients potentially will go into an acute phase of treatment for a short period of time or maybe a slightly longer period of time, depending on how they respond. And then that will be followed with a monitoring period and time off that treatment. And I guess, just to be kind of conscious that that's the conversation we're having in theory, and ideally patients who are in that chapter will have already done a lot of the psychological grappling with the diagnosis per se. But I would suggest that there is certainly a conversation that should be happening around what life looks like for that patient then. As Eugene referred to, like one foot in being ill and being a cancer patient, but also this other foot in life and an expectation of functionality and also an ambition for functionality. And I guess that's really the key question for us in terms of patients. What is available to patients in the first instance? Access is sitting over there as an issue, but then in an ideal world, if we are presented with both options, continuous treatment or fixed duration treatment, I think then we are back into the space where we need to talk about the individual preference, depending on where a patient might be on at the phase of their experience, their CLL experience.
Which brings me, I think, into a nice conversation. And welcome, Dr. Munir. Thank you for taking the time. We just for your benefit, we've covered some of the background on, I suppose, the state of the art of where we are and the psychological kind of perspectives on some of that. But I'd like to now focus maybe, and I think it'd be very interested to hear your perspective on what Jan has just said on the whole, I suppose, co-decision making and what that looks like from your perspective in practice. Every patient is different. How do you assess and come to a partnership agreement on treatment goals, and how are you living that in your practice?
I think that's the first bit really. I think in terms of where we stand in treatment of CLL at the moment is that we've got options there to give to our patients, and I think one of the crucial things now is how to explain this in an easy manner to our patients. To say, you've got this fixed duration option and continuous option. But when you say that for the first time to a patient, it doesn't mean anything to the patient because you're just using these terminologies which are designed by medics to define in a conference, and Costas can just understand what I'm trying to say, but a patient sitting in front of me will take some time to actually digest that information. And what does that mean in terms of how it will impact their life and how they're going to take this information in? And I think we are in that position at the moment that we have got multiple options. When we talked about fixed duration option, we're talking about combinations of an antibody treatment with one drug, venetoclax, or combination of another combination of one BTK inhibitor with another venetoclax and another BTK inhibitor with venetoclax. And then when we go to the continuous therapy, we've got options of ibrutinib, zanubrutinib, and acalabrutinib. So I've already made half of the audience confused by what I'm saying. Giving all of these options to the patient is difficult. And I think what we need to do as clinicians is to give the ample information that the patients require and give them time and space to think about it. Because if I am sitting in front of a patient and I'm confused about finding my hotel, then I think it's the same. It's the same thing is that if I am going to create confusion for my patient, they are going to be more confused than me. And sometimes we all end up seeing these comments being made. You do what you think is right for you, but I want the patient to make a combined choice with me so that I can take them on a journey of the treatment of CLL. And I think That's the most important piece, in my opinion. And that first discussion that should not be the only discussion that you're having with your patient.
And that echoes, I think, a lot of what was said there earlier about time and giving the patient time. Costas, I know that you're a big believer, in the two-way dialogue, and the input from the patient. And on the other hand, I mean, we read things like that in many countries. This up to 70% of patients are not getting information about alternatives. Are things changing?
Not as fast as they should. So we need to invest a lot more time, energy, and we need to educate the healthcare professionals at large, but also the authorities. Unless this changes, it's a paradigm of a physician-centric service delivery, call it as you wish. This has to change. We are all citizens, and as citizens, we need to engage in a dialogue. For this to happen, you need to do two things, or at least I think you need to do two things. One is to educate, but to educate the patients. The other one is to improve physician communication skills. It's something that is lagging behind a lot in many parts of Europe, and there is no formal training about it. And we've seen how standards differ, but it's an aspect where we need to work a lot more. Unless our physicians have better skills and improve their skills about how to convey information, how to be receptive to what the patients say, we will not improve, we will not make our patients, we will not empower our patients in participating in this dialogue and in taking decisions in co-decision making.
Right, fair point. You raise, a point there about, gaps. Gaps are, I think we have a very interesting perspective from both of you, in Leeds University and Thessaloniki in Greece. There are gaps across Europe in terms of, how patients are told certain information, the level of access that is available.
So
Yeah?
To interrupt you, you're absolutely right. Gaps and patients and all of that. But let's face the reality. And Tyler, I would also like your perspective on this. It was irrelevant. This discussion was irrelevant in the CLL domain before 2015.
Yeah.
So we didn't have effective drugs. There was no motivation by anyone. So people's needs were not paid any attention. We were not really caring about all these things that were very relevant back at that time too. So all of a sudden we have discussions, we have patient advocacy groups. So we are experiencing with the delays what you've experienced in CML and what people have experienced in AIDS. So where you would have a life-saving treatment, and we needed to do our best in order to ensure that people would have the best possible outcomes. So let's face reality. We have a unique opportunity today to push. And we need to understand, and I hope that this will happen, that we are on the same boat. You mentioned access, Jan, which is important, but there are many different aspects about the disease where we all need to be educated more. Unless we are educated and unless we perceive the challenges, then we will not improve. And I slightly disagree with you, Felice.
Yeah.
You mentioned that patients with CLL are somewhat advanced in age. This does not mean that they cannot understand. And even if they have difficulty, there is always someone in their family or a friend who can support them in this. So we shouldn't axiomatically think that since they are quite elderly, they don't understand or they don't have the right to participate in this discussion.
Absolutely no. I agree totally. There's a need to participate, but many times the level of education, the level of understanding is not the same. A physician many times uses terms not clear for the patient. I agree with you. Also, the elder people use the phone, use internet. Also, internet give a lot of information wrong, and we need to address also this problem because many times I know patient go to physician, I have this disease, please give me this drug, please this is my future and so and so. Then we need to mediate the communication and patient caregiver, I think, is one of the best way to support patient in their path, because the path of the disease is not path only for patient, but the family live with the patient, the problem. Just to think about the financial toxicity. When your parent, your family member have a problem, and you caregiver help them to with the disease to go in the hospital to make something, you lost work. You lost time. You lost your free.
Yeah, and I think we'll get to that. I think there's positives and negatives. I mean, we've talked about, I think, what the patients get back as well, and we'll talk about. I'd like to turn to the European dimension to all of this, because you did allude to it as well. And Monica, from Myeloma Patients Europe, you've done a tremendous amount of work, I think, and you know what it means in terms of survivorship in what has become a chronic disease, and how, I suppose, the policy gaps and how systems now need to adapt to that paradigm. Could you just tell us, I suppose, a little bit about the successes that you've achieved there and how you see maybe some learnings that you could bring to us to shape the CLL discussion?
Absolutely. Well, it's been very interesting to hear everyone. Okay, mine is not working as well. It's been very interesting to hear everyone, because I think every speaker pointed somehow to different gaps in the system, starting from the fact that you have a different landscape for treatment right now. So that would itself bring a myriad of issues. There's access, even though you do have a lot of options in theory. In practice, it's still, unfortunately, a little bit of the postal code lottery. It's the country, but sometimes within the same country is the region, is the town. It's definitely better if you live in a big city, you're close to a big, center, medical center. Again, it's connected with information, access to information as well, which can depend on the background of the patient and what you're saying, the family, the caregivers play such an important role in this, and unfortunately their contribution is not always recognized at the policy level as well. There is the issue of choice that is related to having more than one options of treatment, but also how to do that treatment. Like in CLL, you have the time of treatment, you have the fixed duration, you have the continuous one. It's getting to the issue of shared decision making. This is something that MP worked on as well, and the result of the survey, of the research that we've done, for example, is show that it varies quite a lot depending on the country, depending on the background of the person, whether or not they even want to have an active part in decision making, whether or not some patients might see it as a bit of a burden, to a high responsibility to figure out what are the pros and cons of each treatment options and having to make that decision. While others want very much to be involved. They would like to be hands-on. They would like to have a very direct relationship with their physician and to be able to play a part, understandably, I would think, in the care that affects their life. Because it's not just about the disease and battling a disease, but also ensuring that the patient comes through alive and well throughout it. And that touches the quality of life aspects, which is such a central issue to the patient experience. And while it's gaining importance in regulatory circles, and it's definitely a very important issue that is to be explored in the relationship with the patient, and on the psychosocial support as well. Unfortunately, that is not as important as we'd like it to be in regulatory circles. There's definitely a more important place for quality of life, for example, in early stages of regulatory approvals. It's in decision-making at the EU level, having patients in the room whenever you have guidelines being negotiated and drafted, when there's regulatory decisions, HTA agencies that actually involve patients. I think you can count them on one hand, basically, in Europe. There are very few. There is a momentum, there is a change that comes with that. There is an increasing awareness of all these things, of the importance of patients and their families to be in the room, to be part of decisions, and the rules that affect them in the end. And the various regulations that are, either have been enacted and they're working on right now. One of being the European Health Technology Assessment Regulation. And patients have had a very important role in that. You could have an argument, it could be better. But it's important to be in the room. It's important for the views to be acknowledged. Going back to the quality of life issue, however, I don't know if you had a chance to see the first JCA report that's been made public. It was yesterday, I think. It was this week. If you go to the section of the carer comments in this, because it's a pediatric drug, so there's no patient input, but there's carer input. You'll see that there is a comment there and saying there's not enough importance being given to the data that refers to quality of life. The health-related quality of life, it's far from what it should be from their point of view.
And could you just talk a little bit, because you mentioned, I suppose we've moved from survivorship to talking now broadly about quality of life, which is progress in many respects. And in myeloma, how, as a patient organization, have you gathered evidence, including quality of life and patient experience data, to really, I suppose, expose or explore the opportunities in these policy gaps to make progress?
Well, survivorship is it's a relatively new issue. And in myeloma, we starting talking about a functional cure, which is absolutely tremendous, and it wasn't heard of 20 years ago. You'd have an expectancy of life on a diagnostics just a few years. So to talk about functional cure, it's amazing. But coming with that, there are various issues. There's, I remember Felicia mentioned about financial toxicity. But there's other things that you need to keep in mind as well. Once either you finish treatment or you're in a stable regimen, is for patients who would like to go back to jobs. Sometimes they're not very good regulations to ensure a smooth transition back to what it means to be a normal life. Then there's something that is called the right to be forgotten. And I think the European Cancer Organizations is working quite a lot on this aspect. It's basically the right of patients who have had cancer, but they had a period of time in which they're not pursuing any active treatment, to not be obliged by law to disclose the fact that they have been cancer patients whenever they want to apply for various types of insurance, not health insurance. So that is there. I think I remember about half of the countries in Europe, in European Union, that do have legislation that concerns right to be forgotten. there's quite a lot to be done there. More so as cancer seems to be moving from affecting people at advanced ages in affecting more and more younger patients. So issues like going back to work, managing a family, having financial toxicity, the right to be forgotten whenever you want to apply for a mortgage. All of these things just come together and make for, even if you do not have to pursue an active treatment, all these are issues that are not necessarily very well managed in various contexts.
Gian, I mean, from the ECLLA perspective and the European dialogue that you're trying, you were on the road to creating. What learnings do you think that ECLLA can take from MPE and incorporate this new emerging CLL story and narrative to build the data, I suppose, as well, that you need to tell the story?
Yeah, absolutely. And I think, as most of you in the room know, ECLLA is very new. We literally launched in January, and we're so pleased that we have so much support in the space. And although we've all been in the community, operating in the community for a long time. And I guess I'm so excited to have Monica here, and I know her colleagues too in MPE, and I'm hoping that they will help us a little bit, because we're so excited about what they've been doing for 15 years for myeloma patients, and on some level we would like to emulate that. I think it's really important that the timing appears to be right to shine a light on CLL and across the board, the diversity of what it's like to live with CLL. And you mentioned, Dennis, about in terms of policy for ECLLA, we launched with our first in-person event in Dublin about a month ago, a policy roundtable. And all of our members, some of them are in the room. I see Lisa Lott there, and I see Ben also. And we had some in-depth discussions about identifying those unmet needs, the gaps in care across Europe. And we would like to take part in the campaign, let's say, to improve the lives of CLL patients across geographic Europe. And we're starting with baby steps. We have plans, and we will be hoping everyone in the room will support us to do that.
Great,
yeah.
great. We will be getting to questions, so you can be thinking, I'm sure, and I'm hopeful that we will have questions for the panel. Dr. Munir, I'd like to turn to you just because we talked, about the European circumstance, we talked about the gaps in education and so on. From a guidelines perspective, are guidelines a useful tool to raising the boat all over Europe? Do you see them as a potential useful tool?
Yes, they are, and sometimes they are not. I think one of the issues with guidelines is that they are just guidelines. They're guiding you to make a decision to help the clinicians to make a decision, and hopefully make the right decision for the right patient. I think that's the crucial bit, really, that the guideline is just there as a document to tell us. And if you look at the guidelines, they are very broad, and they just paint a very broad brush, really, on everyone. But when you see an individual, you're not essentially just putting all the guidelines into that person. You're seeing that as a person, and you need to mold the guidelines around that person to make the right choice for that person. And eventually the issue comes down to, obviously access is an issue, and I get all of that. But once we've gone through that phase, the question then comes around to, if I am going to propose this treatment to my patient, is this the right treatment for this patient? Am I going to go take them through Lidl or Waitrose? That's the kind of options we've got now at this moment in time. And the question comes down to then proposing that, and all of us, all clinicians, will have a bias towards one treatment or another for their patient. And when you are making those decisions for your patients, you have to be very open about it and say, why do you think this is the right treatment for you? And usually 9 out of 10 times, patients will see it and say, yeah, I can see where you're coming from, and let's go on this journey together. Because if you're going to take the patient on a journey on your bus, and they're not willing to ride that bus, essentially you're in trouble. Right. And essentially you need to be really having that dialogue right at front. And I agree with Kostas about the education piece. I think it's important because when when there are so many options, the clinicians also need to know about them and offer the proper choice. So I think I do get the guidelines, and the other problem with the guidelines is they lag behind the real time. So, for example, we see the data on these conferences, fantastic results come out, and the guidelines don't update for another year or two because a lot of our colleagues don't agree with each other how these guidelines are going to be proposed. So, you know, I feel for myeloma guys because essentially that's a minefield at the moment. And you know, if you get 20 clinicians in a room, they can't agree on anything at this moment in time. So it is a useful document. So the answer to your question is it's a useful document, but it's not the Bible.
Right. Looking towards the future, Costas, I know that you're it's a special interest of yours, very much the biology of the disease, and I suppose aspects of what you might call the personalized approach to CLL. How does the future look? I mean, we've spoken about progress up to now. What's your perspective on the future as it relates to treatment-free periods and so on from the research?
The future looks unequal unless we fight against this. Because in the end, we are already experiencing a vastly different landscape of research. So it's the privileged few who have the resources to run high quality research, and then the majority who are simply following. You spoke about personalizing the treatment of patients with CLL. And I believe it's a hype, at least today, because we are relying on only 2 biomarkers in order to take decisions. This is not truly a personalized approach to treatment decision making. Now, one could claim that there are many things in the pipeline, and there are possibilities for doing, for instance, comprehensive genomic profiling. But is this a reality across Europe? And the answer is a big no. And getting back to what we are doing today, and I'm afraid we will be doing for some years ahead, even these 2 biomarkers that I mentioned, the defects in the TP53 gene that we have to assess by FISH for deletions of chromosome 17p and by DNA analysis for detecting mutations in the TP53 gene, and then analyzing also immunoglobulin genes. Even these 2 biomarkers are not systematically assessed in every European country. And I'm putting aside issues of reimbursement, because in many countries, it's either out of pocket or supported by pharma. So there is a lot of exciting research happening as we speak, and a lot more that will come in the next years, particularly concerning what can contain CLL and what are the interactions between the malignant cells and the environment at large. By environment, I mean the host, but also the external environment. And there is a lot more that we need to learn about, for instance, how to restore immune function. Because although we have improved a lot, outcomes have improved massively, we still fail to address this issue. And there's another major challenge. A not insignificant fraction of patients experience clonal evolution. And we are still not there when it comes to understanding what drives it. And if we have ideas or hints, we still don't know if we can intervene. And there's a final thing I would like to bring up. As in other contexts, CLL is preceded by a pre-malignant condition termed monoclonal B lymphocytosis. So this condition is very frequent. In fact, is many times more frequent than CLL. So the question is, do we know who amongst the individuals with this condition, this pre-malignant condition, will evolve to develop CLL? And the answer is no. So there is a lot more that we need to do before we can truly claim that we are offering personalized management in CLL.
Thank you for that perspective. I mean, from a simple man's perspective, I mean, so much, I suppose, going on in the future, but it's important that we get our house in order with the opportunities that we have today right across the board. Coming back a little bit to the psychological perspective, Amanda, looking towards the future, what concrete steps would you like to see to make, big improvements and big impact? I mean, we all talk about, I think, further integration of psycho-oncological care into the pathway. I think that's something that, we all push for. But what's your perspective on what we might call quick wins, or, where we need to be going next?
It's a great question. I think I'm okay. Will you tell me?
No.
Maybe I should.
No.
Okay. I will take the mic. I don't know about quick wins, but I think where places that we can go in the future, I think in general thinking building multidisciplinary teams that really integrate and that know how to collaborate, know how to work together, and that's not a quick win. There's a lot of research even going on. How do multidisciplinary teams collaborate, work together? How are they managed? But I think the more, and particularly when we're highlighting quality of life, things like fatigue, right? The research is really clear that folks with CLL are managing fatigue, and oftentimes with little support or not enough support and acknowledgement and recognition. But it can be things about relationships, this idea of anxiety. And yes, I totally agree, anxiety is a human experience. And the more that we normalize some of that, and also recognize when there's transitions and treatments, the research is really clear, anxiety spikes. So we're asking people to have these different chapters, have these different options, possibilities for relapse. We increase the risk of anxiety that can be disabling, that goes beyond normal. So I think the more that we build multidisciplinary teams, we build, prioritize quality of life as a fundamental part of treatment, as opposed to a secondary component, is really important. The other thing is there are good treatments out there from a psychological perspective. We know cognitive therapies, cognitive behavioral therapies. I practice a lot of what's called acceptance and commitment therapy. A lot of our mindfulness approaches have good outcomes. And a lot of times people, they're not really aware, there's still a myth that people just get over it, or that they just kind of need time will heal. We need to, I really appreciated what Eugene mentioned about we need to be assessing people truly where they're at from a psychosocial, emotional perspective and meet them with the treatment they need. Again, there's a myth out there that everybody needs psychological treatment, everybody needs to see a psychologist, and that's actually not accurate. We don't have the workforce for that. It's inappropriate to pathologize folks as well, but we need to make sure that we're assessing so that people get what they need and we're meeting them what they need, where they're at, when they need it. And again, for a lot of folks, that's going to be referrals out into the communities. And interventions can look very different, just like treatment can look very different for individuals, so can interventions. Interventions might be spending more time with your book club, or going back to church, or for whatever it is for that person. A lot of times one of the things we're doing is trying to see what's worked for you well in the past when you've experienced distress. Can we reactivate some of that? So sometimes people do need, there are evidence-based treatments that are appropriate for some. Other times people just need very low levels support of what's worked for you when you felt distressed in the past, and how can we support that transition. I do think in general I don't think they're easy wins, but I do think, and it sounds like many of us on this panel are in agreement, enhancing communication. And that can be from the clinicians. I also think we need to do better something that I think about a lot is how do we support people in peer support, because crises emerge. And I think it's unfair to ask people and the time and the space and the energy to manage crises that maybe we're trained to manage, but how do we support people in doing that work? So I think there's a lot of work that we could be doing in terms of helping communication at various different levels.
Yeah, you raised so many very valuable points. Thank you so much. Yes?
Hi. I just wanted to make a quick addition to that. A new emerging layer to communication, to care pathways, is the cross-national dimension of things. It's increasingly becoming necessary, especially in rare diseases, to have cross-national communication between physicians, with patients sometimes being referred for treatment in different countries. There is a possibility right now for the EU countries, for the national insurance funds to be able to pay treatments abroad when sometimes, even though they're not reimbursed in their home country. This is a thing that not a lot of people are actually aware of. But there's the emerging network of ERNs as well, the European reference networks, which would be a tremendous a source of information. But there's more to build around that as well. As how do you support a patient who doesn't speak the language when you're referring them to conduct treatment in a different country? How is communication happening between physicians, between different countries? How is that relate to the patients and their families? How do you support people who've been participating in a clinical trial in a different country when they're coming back, and the communication between the clinical trial team and the caring physician, and so on. So this is something that's happening seemingly quite fast, and I feel that there's not the support around that understanding and the communication. It's not necessarily proceeding at the same speed of that development.
Okay. Yes, Eugene, would you like to react?
Just further support what Amanda was talking about. There are no quick and easy wins. I'm 23 years in the role that I'm in St James's, Dublin, and I'm very fortunate that the team that I work with on a multidisciplinary level are very supportive of the role that we have within the hospital. It takes a significant amount of support from top down, from bottom up, from side to side. It needs everybody on board, and we as a psycho-oncology team within a health system need to kind of make ourselves very active and incorporate ourselves actively within the hospital network with our clinicians, our colleagues from various specialities, and be available and be supportive and be responsive to teams around the hospitals.
Right. And I think that's an advocacy message as well. We need to, I think, as an advocacy movement, to highlight that to the decision makers, that this teamwork is so valuable, so important, that they can't be cut back.
It takes a long time.
Yeah.
23 years, and I'm still working on it. But I have a very good support system with my colleagues, so it is working well for me. But that has taken a lot of work on both sides, my side and the other clinician sides as well, to work in a collaborative manner.
Right. Monica mentioned, the transnational part of this. I mean, I know you yourself, Jan, went on a trial in the UK.
Yeah. Yeah, I did, and I guess it's not the Jan show, and Tal remembers me, I'm sure, because Tal was one of my trial doctors at the time. I had to leave my jurisdiction to get access to the next best therapy at the time. Now we have other therapies, but back then it was a huge challenge. We had young kids at home. There was definitely financial toxicity happening for us as well. And I was just so fortunate that I managed to be able to access a place on that clinical trial. I've had a good outcome. I think we, as an advocacy community, we need to empower patients to look to other options if they can't find a good option within their own jurisdiction. That's just what we have to do for longevity. And I think, and I would always advocate for clinical trial participation, because the patient is so well looked after in that setting. And I certainly felt very supported, and I would absolutely take another clinical trial if I needed one in the future. So I think that's an important message too. yeah.
Getting back to today's theme, which is treatment-free periods. I mean, everyone has had their shot, I think, now at the future, and how in this changing paradigm, where would you like to steer the future? What's the most immediate next priority for the patient community now, given all that we've heard today as well?
Yeah, well, I think we're looking at a fantastic opportunity for patients to potentially come off treatment for a period of time in their life and in their experience with CLL. And I understand clinically there are pros and cons to consider, and also from a patient perspective and care partner perspective, a lot of pros and cons. And Felice made a good point about anxiety for a patient potentially stopping their continuous treatment to then take a leap into the unknown and embrace an acute phase treatment for a little while and then hopefully re-enter life with a more functional, in a more functional way. But I think what we've heard so far is that the paradigm has shifted so quickly and so much for patients, and we need to embrace the newer options. It's offering us a shot at potentially even normal life expectancy. I don't know. Maybe that's a bit. Maybe I'm being a bit ambitious, but potentially functional lives for a long time. That wasn't really there 10, 15 years ago for patients. And I think the conversation today really should be looking at, let's just take a moment to reflect on how fortunate we are that now there's another option, another treatment option for patients. But what does it mean? And I think, speaking as a CLL patient, we're always looking around the corner for the next treatment after that. So we might need some reassurance around future treatments, or how, again, this is a question for the clinicians on the panel, we've talked a little bit, we've kind of talked around it, but what about UMRD, and how likely are we to get into that deep remission by taking a leap maybe into a fixed duration therapy, and what would be next for us if we needed then another treatment line? Sorry.
Yeah, no, I think that's the kind of, in my view, ultimately we want patients to go into very deep remission, whether you use MRD or other methods to get patients into that space. The issue really at this moment in time is that there are trials happening which are looking at adapting the therapies based on how well you've responded to that treatment, and either de-escalating the therapy or escalating the therapy. So that's the research piece which is happening, and there is data essentially now saying that approach is, in my opinion, and people can disagree with that, is probably gives you a personalized approach to treat CLL in that space. I think in terms of the two facets to this, really, one is obviously we talked a lot about the access. I think if we go worldwide, the access problem is massive. There's no doubt about that. I think we're never going to be in a perfect world where these things are not available to everyone, which I would personally like that to happen. But I think there are policy things that could be done and that could be advocated, like Costas is mentioning about the IGH mutation status and TP53 status. If it's written in the policy, which NHS has written in the policy, it will happen. Mm-hmm. Even if the clinician doesn't want to, make the decisions, essentially that's in our genomic panel, and that's a policy. So I can't change that policy. And I think that's the advocacy piece that we need to put. Mm-hmm. The other thing is about quality of life. If there is something inbuilt into that policy plan, then essentially we'll have to do it. And I think that is an important thing to fight for in order to advance the field forward. And I think the next step in terms of the direct question that you've asked, Jan, is that essentially, yes, we are getting patients the treatment off, time off treatment, which is very important for some patients. For other patients, no. For other patients do struggle with that as well. And I always tell my patients that that's not your inferior option to what we are proposing you here. So I think it's all the time you have to put what you feel is the right option for the patient, but then keep an open mind about that as well. And I think in future we will be heading towards the words that myeloma guys are using, functional cures, we probably will be heading towards a phase where we will have patients who essentially will go into very, very deep remissions and actually might not need further therapy for a long period of time. And that it would be a very good space to be in.
I'm nodding a lot from the CML perspective. I can echo with just the paradigm. You know, we're very different diseases in many also, but it's that paradigm I think that we would all wish to be able to be in. So there's time for questions. Does anybody? You've heard a multitude of different perspectives. Does anybody have a burning question that they would like to put to the panel? Oh, very good. I'm sure you do.
Ben is behind
okay,
you.
we have to let Ben in. Yes. You know, when I get the mic, I don't like giving it over.
Everything because it's as many of you may know that I do have a tendency to ramble anyway. So I'd just like to thank the organisers in the panel, because this is an unusual panel to come together, and it just offers a depth and breadth of experience that I'd like to tap into somehow, and I think it does deserve a wider audience. So we've heard about the changing landscape of therapies and how that has a social engineering effect on the nature of the relationship that we have as healthcare professionals with our patients. So the sort of tenor of my question is around how does that drive quality of life? How does it improve patient-centered approaches in research, for example? How does it change the perspective on perhaps the relative weight of clinical outcomes and how we measure those as patient-reported outcomes? So we've heard about citizenship in CLL. Now, Plato's Republic tells us that citizenship is not something that is conferred upon us as an automatic right. It's more to do with perhaps the mastery of civic virtues. So I would like to ask the panel, what civic virtues would they like to see developed in patients, in healthcare professionals, to be able to tap into those improvements and the power of the relationship between healthcare professionals and patients to move this agenda forward, which is rather out with the separate issues of access, molecular biology, etc.
Exactly.
Very deep response. Who would like to put on the toga? And,
it's my feeling, because if you think we continue to design the system, health system, as in the past, not in the future. The future, we have a lot of tremendous discovery. The science go on, but the system stay at when cancer was an incurable disease. Time disease. And now it changed, and we need to move forward to design another health system. Included psychological aspect is not, but this is also talking about a rich country, because a low and middle income country have no opportunity of this. We need to put on the table also this. We need to put on the table also in Europe. We talk about cross-border cure. It's not true. It's just in the paper. Because if people from Romania, I have experienced directly, ask to come in Italy to receive a cure not available in their country, she wait 6-7 months after they die before they receive the authorization. This is the reality. People ask for Bulgaria, people to come in Italy for myeloma. But it's not possible because Bulgaria authorized these people to come in Italy because in Italy is a need to pay it. So we have a lot of information on the paper, but not the reality. We need to move forward to redesign the new landscape because it's disconnected by the reality with the science. Sorry.
surrounding us. Thank you. Yesterday, I had the opportunity to visit the Karolinska Institute, which is, ranked as one of the best hospitals in the world. And certainly, when you enter, you feel that. I learned that you're actually an invited professor at the Karolinska. How would you like to respond to that question of, I suppose, new paradigms faced with, realities that we have, but how can we look at virtue and in the context of the question?
Before I answer your question, Dennis, I would like to ask Ben, why did the word citizenship resonate so much?
Why does it resonate so much?
Yeah, because I said something that is very obvious.
I think it's about this sharing of our ability to work within a society together. And it's about standing together to look forward.
You ask about what civic virtues, and I would say that this belonging and collaboration would be something that should be ingrained in all of us. It's not because they are telling us the system is globally trying to make us feel hugely important as individuals. Why? Because they want to break the bonds that bring us together. So unless we work a lot in reversing what your former prime minister, not your former prime minister, your neighbor's former prime minister said, there's no such thing as society, and embrace the concept that disease is a manifestation of life, but shouldn't deprive the unlucky citizen who suffers from this disease from their rights to participate in life, then we won't move forward. And in practical terms, I don't think I need to bring more arguments than mention what happened in the UK, in fact, when Michael Marmot made the observation that in Glasgow, the life expectancy of men living in the richest suburb and the poorest neighborhood differed by 28 years, 82 to 54. So we can't talk about progress in CLL, and we can always be impressed by the Karolinska. I am very impressed. I was there yesterday too. And I'm always very impressed. But does this standard pertain to everyone? And lest you are impressed by seeing this beautiful building, if you talk to colleagues from Sweden, you will realize that very different standards pertain in the different regions in Sweden. And Uppland, which is really next door. I mean, I will go to Uppsala tomorrow, and Uppland has very different standards compared to Stockholm. So you mentioned about postal code injustice. Can it be more crazy when in one of the richest and more technologically advanced countries in the world, it's so unequal, and it can happen just because you happen to live 50 kilometers away.
Yeah, right. Thank you. We have a question? Our Swedish colleagues are nodding.
Yes, thank you. I have a question, and first, thank you very much for all this amazing, very, very insightful discussion and all the different perspectives you could bring. I would like to build on that, grounding us a bit more into the reality our healthcare system are facing. I think we are all very familiar of the financial difficulties, sustainability, that also impacts, of course, access to and equitable access to innovative treatments. And connect the dots with the topic we are addressing today, which is the holistic value of time of treatment. Of course, we have heard a lot about the value in terms of quality of life for the patient, the value also impacting caregivers. I would like to maybe open an additional perspective, which is also the value for the healthcare system. We were talking about healthcare resources. Being off treatment means, not being into the healthcare system, at least for a period, not going to the hospital, reducing probably, of course, there will be always a follow-up and checkups, but of course, that reduce the healthcare, that creates efficiencies, right? So I would like to hear your perspective around that and how we can probably also highlight this narrative into this value. And it also means that people like caregiver will be able to be back into the active role they have in the society, go back to work, and the same maybe for the patients. So all this contributes on an economical improvement.
If I'm allowed, I would like to say something here. We run a big European project. We coordinated a big European project dealing with palliative care. Palliative care is not end-of-life care, it's supportive care. And according to the WHO definition, it's any form of supportive care at any stage of the disease, regardless of the anticipated outcome. Our project focused on CLL as a really tough nut to crack because it's elderly individuals, and what we proposed, or what we hypothesized better, is that by offering an e-health platform, we could seamlessly integrate patient outcomes, and we could facilitate the interaction with the healthcare team. The study is published in JCO Oncology Practice, and it showed meaningful improvements in the quality of life in several dimensions of the quality of life, which made us work towards running a new study. There is a call, in fact, about earlier palliative care, and we are setting up a consortium. ECLLA will be a member of this consortium. And we were talking to colleagues in Denmark. And we also have colleagues from France who deal with HTA. And our idea is that by educating the healthcare team about the benefits of palliative care, they can be more sensitive to the idea, and they can really understand what they need to do at the right time. The major concerns that we heard from both Denmark and France is, do you believe that this will be liked by the payers? Because if what you are planning to do means that we need to hire more psychologists, we need to hire more nurses, then they won't care, and all your arguments about savings, about carers getting back, about days saved, and all of that will not matter. Which brings me to something else. When it comes to real-world data that may inform HTA decisions, the potential sources are endless. From claims to hospital data, from insurance data, even some people say if you are a member in a gym. So all of these sources of data should be integrated. The question is how. And it's not a technical challenge. Experts in the field reassure us that everything is feasible. The question is political, and it also impinges on our rights as citizens. So you are absolutely right in principle. Whether the authorities have the same view is a very different story.
Thank you, Kostas. Have we any questions online, or would you like to grab
online? If we can do one or two of the online
That's
ones.
fine, yeah,
Okay.
please.
Okay, so we have a question from Rita Lyle in Denmark. How can we encourage health professionals to be educated in patient involvement, and how can we as POs patient organisations encourage patients to be more active. It's very important to educate the patients and the relatives too. And do you know, when I saw that question come in, I actually had, when Tal, you were talking earlier on, and it kind of relates to it, you were talking about the guidelines, or when, you know, we come to conferences like this and you see all the data, and then, but it takes about a year or two before the clinicians come together to make a decision on how the treatments or the guidelines are going to be. But what I'm wondering about, and it kind of relates to this question, is are patient organisations and the wealth of information that we have involved in that process? Or is it just the clinicians that come together to make a decision on the...
Well, I think I sit in a privileged position from that perspective, because I think I can see some members in the audience who are part of that patient group voice, really, that is important. In terms of the healthcare impacts of these treatments, that's really a problem. And it's going to be massive in the coming years as the treatments become more and more advanced and more expensive as well. So if I go to my, say, NICE and say, I want this treatment, and this is the clinician perspective, they won't listen to me. They need the patient voice to be there. That they will say, oh, the patients are asking for it and they're shouting for it, then they will listen. And the reality is that these decisions are made above my pay scale. But I'm going to fight for it from a clinician point of view, but the patients also have a voice there as well. And I think in terms of the impact on the healthcare system, these are real issues. And I think some of the things we have to really value is that as the treatments become more and more advanced, don't throw the previous babies out of the basket. Those treatments will actually become cheaper. And as a result of that, you need to really analyze in public healthcare systems what is giving you value for money. And I think that will become a very hot topic in future, and we have to incorporate the quality of life and everything else into the whole picture to get an answer to those questions.
Thank you. We have a question here from the front.
Could I just jump in for a second there, just on that topic? And I think, again, from the patient organisation perspective, and I'm thinking about Rita at home and ask the question, you know, I have a challenge to extend to our industry partners in the room. Patient organisations can do so much. We can support patients. We are a credible source of information for patients at a time in their lives when that is what they need. But we need to be resourced. And, you know, locally we have experience around this, and also now in ECLLA, all of our members are experiencing the same thing in general. We're small organisations, we're volunteer-led, and we need resourcing. But beyond resourcing, we need true collaboration, and I would say, with the exception of the clinicians in the room, you know, there are some areas that we could potentially work with our clinical community that are not yet open to us yet. And I think the challenges that we've highlighted here around patients being empowered to make a decision about fixed duration versus continuous therapy, that's a shared decision-making issue. We can't have shared decision-making if we don't have empowered patients, and it's all chicken and egg. And we really need, I would suggest, to come together as a community and be collaborative, and then we can potentially achieve great things for the patients.
Yeah. Still, we shouldn't ignore the fact that the European Hematology Association guidelines about the management of CLL that came out today are the first guidelines co-authored by patient advocates as well.
Yeah, that session is later today, I think. Yeah.
Oh, I would argue BSH guidelines does have patient advocates, and they came out before.
You're right. You're right.
And there's also the NCCN in the United States who do involve.
Oh, that's
yeah.
Big basket.
I just had a question. When you were mentioning patient involvement in NICE, do you have any suggestion when patient involvement just are limited to almost ticking the box? I was in a meeting with TLV, and we also had representative from the New Therapy Agency in Sweden yesterday. And in Sweden, patient involvement in HTA is 1 or 2 patients. and they don't know anything about CLL. They don't know anything about blood cancer. So how would they be able to actually have an opinion about?
Yeah, no, I agree with you. I think the question needs to be asked from the right person. That's the first thing, who have got expertise. So I think I can see a face in the room who can answer that question. But essentially, the call, when it goes out, it goes to a CLL support association or Leukemia Care, and those are the organizations who, in UK at least, have got very big CLL patient group who can talk about that, and their voice is, I would say, is as important as my voice. Eventually, the decision is made by separate people who are looking at things from clinical data perspective, economic perspective, the impact on the healthcare as well. But the voices that are being heard from different facets of facility, and it's a very tedious process. Don't get me wrong on that.
I mean, it's a new process, and I think there's a lot of teething problems that is the entire patient community is behind you on the point you raised. Monica, you would like to jump in quickly?
Yes, I just want to say that from my experience of looking at various HTA agencies, and I think also in terms of involving patients in decision making, UK, it's a very particular case. It's a highly positive case of that happening. The patient organizations that are extremely professional, very well organized, manage to set up a system where they can access funding as well. Then you have organization, you have like NICE, for example, who is willing to really be open and include the views, for example, accept submissions from patient organization, which does not happen much. The UHTA does not accept currently any submissions from patient organization. The role that we have right now is just finding patient experts to be involved in the process, just to give an example. So it's very much a role model that I think we aspire to, but I think what's happening in the UK, it's very much, there's a very huge gap between UK and I think the rest of Europe and rest of the world, really. But in terms of what Lisa was mentioning, having a meaningful involvement of patient, not having just a ticking box exercise. This is a subject that I'm very much passionate about as well. Within the UHTA, this is something that keep trying to push there at every meeting that we have, is that there is an insistence, for example, that any patient can be involved in it. Any lay patient, anyone who had myeloma, is just, there's no problem to have them involved in the process. And having seen this first JCA report being published and having spoken to several patients who have participated last year, I can more and more confidently say that this is just not true. There's a tremendous amount of time, there's expertise for a person to be able to meaningfully participate in this and to represent communities truly, because if you look in the legislation, the UHA legislation, the criteria for choosing patient experts is that they can represent more than one health system. They could have experience of knowledge of 2 or more health systems in the European Union. To have experience of a health system that is beyond lived experience. There's people who participate in a lot of things, and that's where you have the conflict of interest here. That is not just the UHTA, that is EMA as well, because I think maybe not a lot of people are aware of that. They passed, but then they had the legal issues, and I understand why, but still it's very limiting in terms of the patients that you can involve. Because once you have prepared someone, once you have a patient who's been an advocate for, like Lisa, for a really long period of time and participating in conferences and, giving talks and knowing so much about so many different aspects, that person will have some conflict of interest. Especially if you are leading a patient organization, you need money to Yeah,
Work.
to do anything, to do projects, to do your work, to do advocacy. And that in itself ties you down, not being able to participate in it.
You've raised a Pandora's box, but I think there's lots to be discussed in a community setting. I mean, we are at time. Would you like to make a final question?
If I may just make an observation.
Yes.
So CLL support in the UK, we've been involved in providing patient input into trials. And the way we've done that is by getting evidence. So, for example, at the end of our webinars, we've actually had a poll about what people thought about measurable residual disease. And we've been able to provide factual input into submissions, both for trials and to nice discussions. So I just think getting a group of people and the genuine voice of the community is so important. And I'd also just say that hearing the discussion this morning, we're going to have longer times off treatment, which means fewer visits. So we know that when we visit Dr. Munir, he will treat us absolutely as individuals personally, but we won't be seeing him as often if we've got gaps between treatment. And yet patients will still be worried about the next scan that's coming up. And I think what's really important is that all of us, the patient groups and all the clinicians together, work out how do we support that whole group of people that are off treatment at the moment but need looking after.
Right. I mean, I would ask us to be mindful of people's time because we have to run to EHA and so on. But one, I think you have a final question.
Would you believe, is the mic working?
No.
Yeah. Would you believe loads of questions came in at the end? So I don't know, and apologies to people. But it's kind of, I'll pick one of them, but it's kind of a long question, and I don't know whether we can answer it, but I think it's more that there's points in it that need to be made. But this was a question from Christina in the Leukemia Lymphoma Association in Slovenia. Today, there is a great deal of discussion about patient information and communication between patients and healthcare professionals. This is an area where the patient organisations play a very important role. We serve as a bridge between patients, their families, and healthcare system. However, patient organisations are still too often taken for granted by healthcare professionals. Too few patients are informed about the support available through patient organisations, yet patient organisations provide high-quality support programmes, including psychological support, rehabilitation assistance, and returning to everyday life and work, and many other services. There is also a need to raise awareness among healthcare professionals about the value of patient organisations so that more patients are referred to. At present, we observe that the patients and caregivers who reach out to patient organisations are typically those who are proactive, resourceful, and able to seek out their information. A key question for patient organisations is however, is how to expand their reach and connect with all their patients, including those who, for various reasons, are unable to do or know how to find additional information and support. Thought it was kind of important. It's not really a question, but
no, it's a very valid comment, I think, to be honest, you made so many really great and very insightful takeaways. I think that we can all walk away from today's meeting and help us mull over. I really, though, dwell on your last point, Jan, about this aspect of community and solving these as a community. Today is a true representation of that. I wish you really the best in the ongoing journey with ECLLA. With that, I would really like to thank all of our panelists today for the time, for the expertise, for the sharing, and for the genuine spirit that you brought today. I think you deserve a genuine round of applause. I'd like to thank you all for taking your time to come here with us this morning, to the online audience, to the ECLLA team, to Myrna, to Lydia, to Michael, and so on for making this event possible. Thanks also to the sponsor AbbVie for the support to allow this space to happen and for resourcing it, and to the AV team and the hotel staff as well. So with just this is
Dennis. And Dennis. Thank you, Dennis.
Thank you very much. This is the first step of a series of steps in this process. So I would encourage you to follow ECLLA on social media for the next steps, which will be a European Insights paper and a series of call to action videos, so that you can really follow up on the conversation that has started here today. With that, have a great EHA.
Thank you.